aren't we?
Already?
Yep. So, I'm going to use James as the focal point. There we go. You look beautiful, James.
Thank you.
All right. Welcome to the 50 Shades of Pain show. For many patients, healthcare has become a factory that whitewashes problems with pills and churns out one-size-fits-all solutions with surgery. I'm Dr. Danesh, a native Kentuckian and the medical director of Wellward Regenerative Medicine. As a double board certified anesthesiologist and regenerative pain specialist.
He doesn't have this memorized by now. It's been like a month.
I believe it's time to offer you, the patient, the healing that you deserve. This 50 Shades of Pain show is one way that we empower you to receive sustainable treatment for injury and pain without surgery, addictive medication, or without becoming a victim of a system designed to work against your healing. It will come.
Give him credit. This is his first time he's doing it without it written down, looking in front of him. I'm proud of him. This is good. All right, cool.
Start your healing journey today at wellwardregenerativeMedicine.com. Sorry, wellwardmed.com. I'm flustered now. I can't see myself either. It's too small.
Okay.
Today I'm with my co-host, Dr. James Escaloni, who is a physical therapist and our biomechanical expert here at Wellward Regenerative Medicine. So James, while I fix the camera, why don't you tell us what we're talking about today?
We are talking about patients who've had issues with sacroiliac joint fusions, why they're still having pain after the sacroiliac joint fusion. So, for those of you out in the audience, out in there in internet land, wondering what we're talking about, has somebody offered you or one of your loved ones, after you've had some sort of fracture, a fusion to your sacroiliac joint? Rod sticking things together, yeah? What about if you have arthritis, degenerative disc disease, regenerative joint disease only in your sacroiliac joint, and the only thing somebody said, only thing we can do is fuse this? Or have you already had a fusion because somebody said that's your only option and you're still having pain? Why does this thing hurt? These are the cool facts we're going to find out talking to this guy right here. All right, so Dr. Danesh, help us out. What exactly is a sacroiliac joint fusion?
So the sacroiliac joint, and I'm not showing my butt because I've been working out with James, meaning that I'm not showing off or anything, but I'm showing you my butt because I want to show you where the sacroiliac joint is. It's this joint right here. There's a triangular bone called the sacrum, and then there's the ilium that runs like this. In fact, I'll go grab a model in just a second and show you again, but the sacroiliac joint, people often think that it's not a joint that's very dynamic, and it's true. It's not like your elbows and knees and hips, but it is a joint that moves, and every time you're walking, it's the alteration of that joint with the slight rotation of the ilium that allows you to walk without that duck gait. Without that joint, you tend to do that kind of side to side shuffle. I know this was really popular with me walking last time, but you've seen people when they walk, it's like this kind of stepwise shuffle as opposed to a nice gait. I'm going backwards. As opposed to that nice gait, and it's because of that, the flexibility of the SI joint along with the mobility of your spine that allows that to happen. Now, what happens if we fuse that? Well, the problem with that is that every joint in your body exists for a reason. It's distributing load in a way that doesn't overload one particular part of the body. So when areas of the body become stiff or immobile, it's actually stressing out other parts of the body at the cost of, by protecting that one area. So it's extra load somewhere else, but less load in one place. And when the SI becomes really lax and really mobile, if you fuse it, you're actually going to transfer more stress to the lumbar spine and more stress to the hips, as opposed to redistributing it throughout the body.
So I think that makes sense, that if something's moving way too much, you want to decrease that. But if that's what happens, why would anybody want to fuse that?
Because there are times where through trauma, like major falls, big accidents, people who have connective tissue disorders, that joint can become so mobile that just simply rolling over in bed creates this radical shift in that clicking and popping. It comes along with like these jolts of electrical pain. People can often feel that going into their legs, not because there's a nerve that's being pinched, but because if let's say, for instance, we were hammering and I accidentally hammered your thumb, you would find that it's not just the thumb that hurts, but the whole hand starts to throb. And it's because the nerve signal coming out of your thumb is so loud, your brain can't tell where it's coming from. And similarly, ligaments are very, very sensitive to like radical shifts or changes. And if your SI joint is so dynamic that now just simply moving and rolling causes that shifting to take place, that can be excruciatingly painful. So there are situations in which, yeah, it's unavoidable. It's without that, it's going to be really difficult to continue functioning. But I'll say that is exceedingly rare. Most of the time, before the SI joint degrades to that point, there's so many things that can be done to intervene and improve upon it that never allows you to get to that point of that radical dynamic joint.
Okay. Well, what about the opposite end of the spectrum? Some of those patients who are told they've got degenerative joint disease or arthritis into their sacroiliac joint. Doesn't that mean they're moving less when it gets arthritic?
Yeah, that's been a point of contention for me, but because first of all, arthritis in an SI joint is like a very late stage problem. But you're right. If it does get to that point where it's now an arthritic joint, it is going to be less mobile. So the mobility is not what's causing the excess mobility is not what's causing the pain. It's the evolution of that arthritic problem that is what's painful, and that can be one of many different sources of pain. We think of pain as being an erosive problem, and it's the erosion that causes the pain, but that's actually not true. The erosion is just one small segment of the pain problem. The bigger problem is the instability that led to the erosion that's now leading to bone pain. And that instability is typically ligamentous pain. It's ligaments that are stressed and strained because some of the other ligaments aren't pulling their weight, or it's tendons and muscles that are stressed and strained because they're trying to keep things together, where ligaments should be the ones that keep things together. So the person who has an arthritic sacroiliac joint, my first question is it really truly arthritic? Because very few people evolve to that level of degradation. But among those who continue to have pain and show signs of arthritic changes, it's more often a ligament source of pain with secondary cause being the bony pain. And it's really important to figure those out before you commit to something that can dramatically alter the biomechanics of your body.
I mean, this sounds like a pretty good question for people to ask, because a lot of people are saying, I've got arthritis in my SI joint, that's where my pain is, I need a fusion. So would an MRI show up that their ligaments are the pain problem?
No, it wouldn't. In fact, MRIs and x-rays often don't show sacroiliac dysfunction until it's a really, really late stage problem.
Really?
Yeah, because what does an MRI or an x-ray show? An x-ray is primarily looking at bone and some soft tissue. It can see some soft tissue that's really thick. But for the most part, most of what an x-ray will show you is changes that take place in bone. And what changes in bone is, as the bone evolves and becomes more loose, your body tries to create stability. And it does so by creating bone that moves into the ligaments and tendons that attach to that area. So bone grows towards inflammation. And if you've got a ligament or a tendon that's constantly flexed and damaged, that's going to cause some inflammation, and your bone is going to grow into that. So it will show past changes, but it's not really showing active changes. That's the limitation of an x-ray. What's the limitation of an MRI? Because we think MRIs are, they're the eye in the sky. It sees everything.
Mm-hmm.
But the problem with an MRI, and we've talked about this in previous shows, is it cuts slices in 2 dimensions, but of 3-dimensional structures. So for instance, it'll cut like this, where I get to see the cross section of my arm, but just in a 2-dimensional plane. And let's say I've got a problem that's going this way. Well, if I'm cutting it like this, I got to be really lucky to be able to see the defect on this pathway that's going in and out of this plane. So the radiologist would have to get a cut that goes like this. And that's sometimes really hard to do if we're talking about 3 dimensions in the body where things are going in every direction. So it'd be like trying to get a slice of the road that's perfectly perpendicular with the road. Well, hills and bumps and curves and all those things exist in a road, so it's really hard to get that visual and to have that expectation that a radiologist would be able to see that is unrealistic.
So this is kind of the pathway that a lot of patients go through. They start to develop some pain. They start to get some pain around their SI joint, and then they go to a surgeon. They get an MRI, and then the MRI is saying, "Oh, there's arthritis there." That's because that's the only thing they could see. And then, unfortunately, it sounds like the surgeon would say, "This is the best option I have to fuse this already arthritic thing to stop the thing that's not moving from moving more." Am I catching that right?
Yeah, I mean, I don't want to throw surgeons under the bus. There are a lot of really good surgeons, and they do this for the right reasons. But I will say, I think that this is one of the areas of healthcare deficits where cost incentives or reimbursement incentives can kind of nudge you, well, this is right on the fence, well, let's just go ahead and do the fusion because it's what pays the bills. And unfortunately, I think that happens in every field, and it's really tragic when it happens in medicine, but I have to be honest, it happens. So, there are ways to testing that if it's worthwhile to even consider a fusion. But even those, I sometimes see people getting the fusion before they've tried a lot of other things, like just basic stuff like physical therapy or sacroiliac injections, where we're not just trying to numb it with steroids. We're actually trying to stress different parts of the joint and figure out what part of that joint is really dysfunctional so we can facilitate the physical therapy and rehabilitation to work on those elements. And that's not even scratching the surface on the regenerative stuff. I just want to make it clear that even for people who don't have access to a really good regenerative specialist like what we do here, that there are ways to address those things without jumping to surgery. Surgery really ought to be the last resort for any kind of fusion. And unfortunately, I just see the bar getting lower by people jumping into a surgical fusion. I mean, I get it. People who are dealing with the pain are in the mindset, you know what? I'll do anything. Just get it down to 50%. Just get it down a little bit. There's a level of desperation, and there's this notion that surgery can fix something. Like I remember as a kid, I used to think that a surgeon could make me bionic. Like if I had something wrong with my arm, I go to a surgeon, and the surgeon would make me even better than what I was when I was born.
Iron Man parts.
Right? We all have this illusion of Iron Man being like the surgical fix. Mm-hmm. And it's just not true, because the body is not like a robot. The moment you start to cut into it, you're creating scars, and those scars are really hard to undo. It takes a ton of rehab to resolve that. And a lot of people just, I didn't have surgery to trade out one problem for another problem and do 6 months of rehab after that. So it often they often don't get the rehab that they really need to resolve that problem in the way that surgery was designed to do.
Okay, well, let's take a perfect scenario. You get somebody with some SI joint pain, and they need that taken care of. And let's just create some sort of model right here for people so they can know what to get after. What should they go through?
So the first step is some variation of what we do as pain mapping, meaning that somebody needs to really do a thorough physical examination, figure out what are the specific ligaments and structures and support structures around that joint that are not working properly? What are the biomechanics of movement that have led to this structure becoming wobbly? The second is to confirm it by doing some test injections where you're numbing not the entire thing, because the way I was trained to do a sacroiliac injection is you find the joint, you go into the joint, and you just do a single injection to spread medication inside the joint. And to me, that is mildly therapeutic, but really not of great value, because every single one of those patients comes back to me in a few weeks and says, well, the pain, it worked for a while, but now I'm back to where I was to begin with. I burned that bridge a long time ago. I mean, it felt like this was just a revolving door, and I just stopped doing my SI injections that way because it doesn't add a lot of value. So what I do now is there are 5 major ligaments to the sacroiliac joint. There are some other ligaments as well, but those 5 are the ones that I really want to evaluate on an individual level and figure out what's the relevance in this joint. So I will target each one of those ligaments independently and see what's the level of sensitivity and what happens when I numb that structure. Because in doing that, now I can build a map of what are the different structural elements of that joint that are failing, and what do I need to do to get that rehabilitated. If we can get the patient towards a regenerative pathway, there's a little bit of a deviation. If we can't do a regenerative, because it isn't something that insurance yet covers, but it is of great value. But let's say somebody can't do that. Well, once we have that map, now you and I can work with that patient and start doing the right exercises that can, if not strengthen those ligaments, then at the very least strengthen the structures that support that ligament, so that the body has to rely less on that damaged structure and give it enough time with the appropriate stresses to get stronger.
You've got 3 big questions that popped in my head, so maybe you guys do too. You said that the way that you were trained was to stick the sacroiliac injection into the SI joint and bathe it with this medicine. So it sounds like that's the standard across the board.
Right.
Because he went to a very good school, Johns Hopkins. You got to be smart to get in there. Just throwing that out there.
They let anyone in these days.
But if that's the standard there and it wasn't working consistently for you, this might be giving consistent inconsistencies across the board for people.
Correct. Because the standard approach is you go through a series of these injections, and when they stop working, then you go and have a fusion. And that's been true for a lot of orthopedic processes, is we have these imperfect ways of doing this mock therapy where it gives everybody involved an illusion of improvement, where I inject it for a period of time, it's better, everybody thinks it's the steroid, everybody assumes inflammation is the devil. None of that is true. None of it is true. Because inflammation is the way our body heals. It's the mechanism by which our body knows there's damage, that it needs to recruit cells to the area to do the repair, that the chemicals that sensitize nerves in that area are part of that inflammatory process, and they're meant to help us become aware that there's damage here and we need to provide some rest or rehabilitation. So inflammation is not the devil. Suppressing inflammation does not provide therapy. Essentially, what hurts and what is damaged are 2 separate independent things, and we need to think about them as different things. When you start looking at it from that perspective, you understand that when I was doing those steroid injections, sure, I'm suppressing inflammation and thereby desensitizing some of those nerves that have been hypersensitive, but I'm not fixing any damage. And so, in fact, I'm actually degrading that joint even further, because we know that steroids are toxic to cartilage, that they loosen and soften ligaments and tendons, meaning that a joint that is already unstable is going to get even more unstable over time with each iteration, each time I do that steroid injection. So I'm providing a short-term benefit with that steroid injection. This is me as in like when I was 10 years old, or 10 years ago. Rather.
He was that good. Doogie Howser here.
that when I was doing those sacroiliac injections and I was going into the joint, it suppresses the inflammation and calms the pain down, but it's also degrading that even further. So with every time I do that, it's going to get weaker and weaker and weaker, and inevitably, yeah, that patient may very well end up in a surgeon's office because people have received this illusion that what should be working isn't working, and that what should be working would never have worked to begin with. The best that it would do is wash away some of the irritants, lower the inflammation, and give the body, if they're doing diligent rehab, give the body the opportunity or the space to do the exercises that would have gotten the patient better in the first place had we never even touched them with an injection.
Well, I think that answers my first question pretty well. Second one is more for people out there, but it does with you. If they ask the question, will you write down the answer to those 5 ligaments you test out on the page for the comments?
Yes, yeah, I will write those out. So the iliolumbar ligament.
Oh, you got to leave it for them to do.
Oh, okay.
They got to earn it. Yeah.
All right, so you have to come back, and then James and I will...
You just put a comment on the Facebook page even later on, so you guys who are curious about this, maybe testing it out yourselves, doctors in training. Oh, yeah.
Oh, yeah.
This is for you.
Yeah, the PT's in training, too.
Exactly.
Yeah.
Now, here's the last one. You mentioned regenerative medicine with that. How would regenerative medicine do something for this, and what exactly is the regenerative part?
So what are we doing with regenerative medicine? We're leveraging inflammation. We're using the good parts of inflammation and leaving out the bad parts of inflammation. What are the bad parts of inflammation? Anytime there's damage in the body, there's debris. And that debris has to be gobbled up before you can start rebuilding. The problem is that sometimes the rate of debris or the rate of breakage is outpacing the rate of that gobble up. So it stays in that chronic inflammatory state because your body's just never getting to the point where it can start to rebuild. Or it's never getting the resources or nutrients to rebuild. Or it's never getting the right stresses that give the blueprint or the instructions to your body on how to rebuild. So it stays in that chronic inflammatory state, not because the inflammation is the problem, but because there's damage and the inflammation is the response. So regenerative therapy is essentially provoking or promoting that inflammatory process, but not putting in the debris. In fact, we're washing away the debris, but we're washing the debris with medications that stimulate a migration of resources to that area that will then work towards rebuilding and strengthening. So once we have that pain map and we know which of these ligaments is the main culprit or which of the tendons that layer down in that area are the problem sources, then we can be very discrete and specific about what structures we want to provoke versus which ones we want to just relax. Because the resources that migrate to that area, we don't want to dissipate them to everything. We want them to focus on the worst problems and focus on fixing or strengthening those ligaments or tendons.
Okay. That sounds like modern scientific evidence at its highest mixed with holistic healing. I kind of like the sound of that.
It's almost like we're actually applying common sense to how the body repairs. But it's not common sense because people have these certain assumptions, like inflammation is the devil or that SI pain is because of arthritis. We've made these assumptions because that was the knowledge that we had at that point. The problem is we never really evolved from that. We never kept asking, well, why? What's behind this or what causes that? And if you start to break those questions down into the more discrete whys, like, Simon Sinek?
What is your why?
Yeah, that guy. So, if we start to look at the whys behind why do we hurt? Why do we do steroids? How does the body heal? Or why does the body not heal when it's supposed to? When you start to ask those questions, the answers are there in the literature. I mean, we could have a whole show about just the literature behind regenerative medicine. It's just putting them in the right sequence to get the full big picture.
Okay. So how exactly does this fit into your heal philosophy? Well worded.
Right. So hearing the message that your body is conveying with pain, envisioning what life or what your goals are, what life is meant to be like, alleviating the symptoms and then leveraging repair processes. So we're going through that whole heal process by identifying the specific ligaments in the sacroiliac region that are problematic, the specific tendons that are not loading properly in that area, or the way the whole dynamic of the system isn't working properly. We want to understand that. We want to understand what are the goals. Are we looking at, I just need to get through this wedding, or are we looking at, I want this to be over, and building a plan for the long term so that we don't get you just feeling good, but we actually fix the problem so it doesn't keep coming back.
Mm-hmm.
Alleviate the symptoms, essentially building that short-term plan to get you comfort, get you better enough to where you can deal with this and get to the more long-term plan, which is leveraging repair processes using either regenerative science, regenerative interventions, or exercises and techniques that are covered by insurance, like dry needling, electroacupuncture, manipulation, all of these things that you do so well. We need to help the patient decide what's within their means and what are their objectives. Are we able to go into the regenerative pathway, or do we need to get as much healing as we can done with some of the standard approaches, and if ever needed, then switch over to the regenerative pathways?
Gotcha. I think that answers my questions about the heel.
Yeah.
And everything about the sacroiliac joint.
Right. I have to show you the skeleton. Can you wait 1 second? Sorry.
Man, I hope you guys aren't too bored because I got stuff to do. I'm hungry. I got a Mento over here, one left. It's calling me.
All right, I'll do the walk one more time. So, this is how a normal person would walk. This is my
With a skeleton attached to their butt.
sacroiliac joint. You see, it's like that loosey-goosey walkie. I don't have really good form. I can barely see myself in the picture, and I can definitely see I'm walking with a slouch. So, not great form. But you get the point. This is the sacrum right here, this triangular. Maybe you can show them.
Sacrum is right here.
Yep.
Ilium's right here. This is where the back ends, and right about from here, right next to the buttocks, all of this stuff right here.
Yep. So you can see how the entire weight of the body is coming down on this one triangular bone, and it's this joint that's shifting, that's taking all the stress of the upper body and distributing it on the thigh, on the hip. Thank you, poor guy. All right. Well, that wraps up our show for the day. Thank you for watching the 50 Shades of Pain show, where we examine the spectrum of shades that make up pain. Each patient is unique, and there are numerous factors that contribute to your pain. In that spirit, we honor each patient as an individual and tailor treatment plans specifically designed to optimize your health. I encourage you to follow us on wellwordmed.com and join our healing journey every week here on Tuesdays, 6:30 Eastern Time, where we cover our 50 Shades of Pain show. I'm Dr. Danesh.
I'm Dr. Escaloni.
And we encourage you to start your healing journey at wellwordmed.com. One day I'll get this.